Sada bih vam predstavila naše sljedeće dvije gošće. Jedna od njih je Megan Gayford, koordinatorica projekata pri Svjetskom programu za hranu. Sredinom 2015. pridružila se organizaciji Save the Children UK kao specijalistica za prehranu. Surađivala je u sklopu UN-ove agencije za izbjeglice u Južnom Sudanu i regijama Azije i Pacifika kao specijalistica za prehranu u kriznim situacijama pod organizacijom UNICEF-a. Pri Uredu za koordinaciju humanitarnih poslova UN-a ima iskustva u planiranju nepredvidljivih i katastrofalnih situacija na regionalnoj i nacionalnoj razini. Uz nju će izlaganje držati Min Tram Lee, trenutačno radi kao Infant and Young Children Feeding in Emergencies prehrambeno-tehnička savjetnica u regionalnom timu organizacije Save the Children, lociranom u Grčkoj s fokusom na države Balkana. U posljednjih 6 mjeseci zaposlena je u Grčkoj i Makedoniji u službi potpore državama koje se nalaze u kriznim situacijama uspostavljanjem centara za majke i djecu, Mother and Baby Areas. Prije toga surađivala je s brojnim neprofitnim organizacijama u Indiji, Afganistanu, Pakistanu i Zapadnoj Africi pri programima za prehranu i zdravlje. Megan Gayford i Min Tram Lee održat će izlaganje pod nazivom Operativne smjernice za prehranu dojenčadi, najmlađe djece u izbjegličkoj migrantskoj krizi s primjerima implementacije.
Hi, good morning everyone, and thank you for the kind introduction and invitation to present today. Okay, so my name is Megan. I'm the Senior Humanitarian Nutrition Advisor for Save the Children UK. I'm based in London, and I've had the opportunity to be the technical backstop for the organisation for Save the Children's response across Europe. I'm joined by my colleague Tram, who is a technical advisor for Save the Children International, and is currently based in Athens with a regional oversight to our IYCF programming. We also have some of our colleagues in the audience today from Save the Children from both Serbia and from Croatia. Okay, so I would today like to briefly cover infant and young child feeding in this particular emergencies, drawing on our experience working in this operational context. I'd particularly like to cover the development of the interim operational considerations for the feeding support of infants and young children under 2 in this context, how we applied this new interim guidance and what we learnt from it, most importantly, and what we see as some of the next steps as a collective nutrition community. Okay, so I think Martina set the stage very well in terms of some of the challenges for this population. So I won't repeat any of it, but just to perhaps give some of my initial observations from being deployed to this emergency very early on, so back in September. So we saw an incredibly stressed population. We had huge numbers of refugees and migrants arriving at the different borders. I think there was a total overwhelming of the national capacities, which is understandable given the size of the crisis. We had very poor coordination, not just in nutrition, but across the humanitarian community and the national authorities. I think for me, this is one of the most perplexing parts of this emergency, having been a coordinator and a nutritionist in a variety of contexts. To see the context here in Europe, I found it was very challenging, given that I feel like we know what we need to do in emergencies, particularly in nutrition. We have standards, we have experience, yet the application of that in this context was very, very challenging. We had many women, we had many children, many families on the move. Many of them were wet when they arrived, they were cold, they were also sick. And there were many women who were asking for infant formula. We had a higher proportion, we know, in this population coming from Syria who have chosen not to breastfeed. So how are we going to meet these specific challenges? We had our observations earlier on in this emergency, and Save the Children rapidly scaled up their service provision, starting actually in Croatia as the first site, and then expanding to Greece, and now Macedonia and Serbia as well. we knew that we didn't have enough information about the context. I felt like we were really operating just on our observations and trying to apply what we knew from other contexts to this context, but there was still some tension and some disconnect. So we set out to do an actual IYCFE detailed assessment, drawing on the experience actually of UNICEF's assessment in Serbia in November. So we were able to interview 150 mother and infant pairs. And this slide, and I apologise, it's quite small, but I'd be very happy to share with you the report from this assessment. But when women were asked what are their biggest barriers to breastfeeding, the first response, the most prevalent response was, I don't have enough milk supply. So I think drawing on what Martina said about stress and it actually not affecting, this really being somewhat of a myth, that it's not affecting milk supply, but the context doesn't support the letdown of the milk. I found very interesting the second most common cited reason for not breastfeeding was concern of the caretaker over their own nutritional intake and their access to food. I think this speaks to the complexity in terms of the transit setting and also the food distribution that was available. Stress, the caretaker being ill, were also big responses. And we'll see lower down on that list was inadequacy of privacy. When looking actually in detail at what the feeding practices were, we saw that, which confirmed what we already knew, but there was very much suboptimal breastfeeding practices. We had only we had 41% of infants being exclusively breastfed, and we saw a variation between the different population groups coming from Afghanistan and Syria. Just to also caveat this assessment, we only assessed two population groups, from Syria and from Afghanistan, mainly due to restrictions in our interpretation. Caretakers were using bottles, they were dirty, we didn't have adequate cleaning facilities, and also complementary feeding, I think, came out very strongly as being vastly inadequate, and this is something that I think we're still struggling with across this response. How do we ensure adequate complementary feeding, adequate and culturally acceptable foods for this population? And finally, on the assessment, in terms of the health of the child, I think Martina also outlined the risk profile for this population, leading to what we know results in increased illness. So in the last 2 weeks, the caretakers cited that 37% of children had diarrhoea, 62% of children had a cough. If we think back to late last year, we're also coming into the winter season. The conditions were very, very difficult. And almost 15% had a proper respiratory infection. What I found astounding in this assessment was that almost every caretaker said that they had a serious problem with their child on this journey. Okay, so why did we find this so difficult? We were in Europe. I think from conversations being based in London, being deployed down to Greece and to Hungary, to speaking to our colleagues who are based in New York, in Amman, we came together, I think, as an international community because this was such a challenging context. Also linking to what Martina said about working in the African context, I've worked with huge refugee populations before. One particular example in Gambella in Ethiopia, where we had 250,000 refugees, and amongst that population, I had 3 non-breastfed infants that I needed to manage, or needed to support the caretakers to manage. So why was it so difficult? Okay, so we had as has been spoken about, the transit setting. At some points, we only had 10 minutes or less with women as they moved through the service provision sites. We had changing policies across the route on a daily basis. We didn't know where the refugees would be, where they were coming from, where they would be stopped at the borders. So we really needed to change our approach. We needed much more of a mobile service provision. We had a lack of trained service providers. I think the discussion that we were having globally was we don't have the right people and we don't have them in the right place. We don't have them speaking the right languages and they don't have the right skill set. Incredibly challenging context. We had a limited option in terms of supporting behaviour change communication, which is, I think, what we base all of our IYCFE interventions on in other emergency contexts. Huge cultural and linguistic diversity of the population. We didn't have the resources that we needed to support the non-breastfed child. That was very clear and continues to be a challenge. My colleague Tram will speak through a little bit more of the operational side of those challenges in a moment. We also experience the challenges with the cross-border coordination. So people moving through borders very quickly, we didn't know where the service providers were, and we weren't sure of the quality also. So in terms of linked up services, referrals between countries, it was incredibly challenging. We also had the diversity of actors, which I think is it characterises the Europe response. Never have I seen such an incredible volunteer base as I did and continue to see in Europe. As an international NGO, what we would refer to ourselves as perhaps a formal humanitarian architecture. I think we've never been such a minority in a response and had to work so closely with so many different actors. And then, of course, we have the issue in terms of how we would describe the low sensitisation of IYCFE standards amongst those actors. So while we saw some excellent practices, we also saw some really just blatantly dangerous practices as well. We've seen these guidance before in Martina's presentation. I put this up here because it just didn't work. What we have here set the standards, and I think Martina again has outlined very well what we should be doing in an emergency. But then in Europe, trying to apply these standards, this guidance, it didn't fit. So this prompted an interagency group of UNICEF, of UNHCR, Save the Children, the Emergency Nutrition Network, to come together and say, okay, this is not working. We need something that's more operational. We need something that we can apply that's very practical and will also speak to other actors, so other volunteer groups that are providing services. So very quickly, we developed the interim, what we refer to as the interim guidance. And we aim to outline what are the benefits, the risks, the options and the resources for this particular context. I won't go through the key considerations. I think they've been covered quite nicely. Okay, so I'm going to hand over to Tram to speak more about the operational aspects. Okay.
Good morning, everyone, and thank you, Megan. So for this second part of the presentation, as said, I'm going to focus a bit more on how we used the interim operational guidance to implement our activities across the different countries and meeting the needs and the challenges that were described before. So the first consideration, we based our ICF programming in the different countries based on two main considerations. The first one being obviously that breastfeeding mothers need identification, protection, and active support. To do so, we established different mother and baby spaces in different countries where mothers were able to come and to find a comfortable, a safe, a private spaces where they would be able to breastfeed their babies. The space was also available for pregnant women, for non-breastfed infants and their caregivers, in order to have this space to play, to enhance caregivers and child bonding, to meet the basic needs as well, changing the nappies, giving a bath, being procured of non-food items. In those spaces, we call them the YCF counselors, but it was trained staff, nutrition-trained staff, were able to go through this rapid assessment or the full assessment of the feeding practices of the mothers to target what were the potential difficulties and provide advices, support, basic psychosocial support also. And that was also a point of referrals to medical providers if there was any medical conditions for the mothers or for the babies, to protection actors as well, to information centers. I think what is important, I know that there will be a full topic on it a bit later, but I think what was important also is that those mother and baby centers from most of the location were located just next to the child-friendly spaces run by Save the Children or other NGOs, meaning that we could have the MBA, the mother and baby areas, and the child-friendly spaces in a protection area where the mother is able to come with her babies, but having her other children, if any others, just playing next to her, and then she would feel free to stay in this private space, breastfeed the babies. Yes. So in those centers, obviously, we were using a clear YCF protocol. So this is an example of Operativne camp that was run by Save the Children together with UNICEF. So this is just an example of the decision trees that we were using with, at the top, infant and young children, and then the rapid assessment, and you could see the different categories, the different alternatives and options that were offered to support caregivers from infants that were non-breastfed, for example, mixed-fed, breastfed, and then the different referrals. I mean, they could go through supportive care with key messages, and we could go to artificial feeding support as well. So the second consideration for our programming, and not the least important one, was that formula-dependent infants indeed needs identification, protection, and support. As Martina said, we know it. We know that using infant formula in refugee settings, in camps where you can't have access to safe water, when you can't boil the water, you don't have equipment, you have such living conditions that the use of infant formula will jeopardize the life of infants and young children. We know as well that in this context, with people in transit, coming from Greece, coming from Turkey to Greece, staying a couple of hours or a couple of days, and then leaving for the next countries and going in the train, coming from the boats. I mean, people being in transit, the use of infant formula was even riskier and more difficult to manage. Newborns are particularly vulnerable, if not the most vulnerable, during this crisis. And the guidance said, the interim guidance said that it's not possible to provide all of the supports considered necessary when using this infant formula, meaning that in many conditions, in many situations, we had to compromise. When we said that some mothers had only 5-10 minutes with us, and then they were coming from the boat or coming from the train, and they needed to rush to go to the next camp or to the next stations to catch the bus, to catch the train, and what their main concern is maybe just to come ask for the infant formula, but what they need is to not get separated from the rest of the family, is to maybe get the other essential food items, maybe get information to know where to go, and literally all of this within 10 minutes. So they were coming to us and asking for infant formula. We had to compromise. We had to admit that sometimes counselings were not possible. Targeted distribution was difficult to complete. So another challenge that we had also is in terms of coverage. We said at one point that there was a lack of YCF service providers, meaning that there was a lack of people trained, sensitized on YCF. So we've seen situations where people were calling and saying there is free donation of breast milk substitutes, juices, infant formula, chocolate milk, and what should we do then? So how difficult it is to say, yes, indeed, this shouldn't be distributed as such, or there are guidances and people need to be trained, but there is nobody on the field. There is nobody to refer to. So what were the compromises when you really have a mothers coming and asking for feeding bottle, for infant formula? So just to keep, to focus again on this consideration number 2 with formula dependent, the way that we have implemented it using the interim guidance and the operational guidance was the procurement of ready-to-use infant formula, the relabeling of the powder infant formula as well. But all of this after that was a targeted provision, so we did it after a rapid and a full assessment of the mother's feeding practices when possible. we were providing complementary feeding also. The most important point here is that this wasn't done inside the mother and baby area, but separately in a different space, to do it discreetly and out of sight of mothers who were breastfeeding in order not to discourage the practices, because we were providing as well those safe breast milk substitutes kit as per the guidance. And this could be seen as a very valuable item that we were providing to some women and not to the others. So that was an important point also for us. There was possibility to sterilize the feeding bottles, for example, for the mothers to come to boil the water and to prepare feeding bottle, which is another gray area for us because we weren't distributing feeding bottle. We didn't have any stock, but because we were promoting and we are still promoting cup feeding support. But some mothers came and they received feeding bottle from different actors, or they were already using them and they didn't want to use cup feeding. So what was the alternative? Cleaning the bottle was the essential for us, meaning that rather than using a dirty one, at least we could sterilize them. But what else could we offer to these women, to these mothers who didn't want to use the cup? But we did have cup feeding support as well. The last one is not the least important either, management of breast milk substitute donations. So as we said, there were a lot of donations, so we are still doing a lot of capacity building, a lot of awareness sensitizations during general coordination meeting, during working groups, food security, protection, health working groups, to sensitize as many emergency responders as possible. We said that there were a lot of different actors involved in this crisis, so there was also a high need to sensitize everyone on what is our YCF, what are our priorities in terms of spreading messages regarding breastfeeding and then minimizing the risk in terms of artificial feeding. So all this implementation, we have come after a few months. We have listed a couple of challenges, of course. So respecting the interim guidance, the operational considerations, and with this so challenging context, changing on a daily basis and still changing today, we have listed a couple of challenges, and I think the first one was really this high sensitivity in terms of infant formula use. As Megan said, in a lot of crises where humanitarian actors are used to respond, you don't have to use infant formula, we don't need it. But here, there was a demand that was, if we wanted to be efficient, if we wanted to properly support mothers of children under 2, we needed to have a stock of infant formula, of ready-to-use infant formula, and we've seen how difficult the procurement has been, how difficult the understanding as well from the different actors is. The safe breast milk substitutes kit was another challenge. So this is really based on the operational guidance. We tried to minimize the number of items in those kits. And so for non-breastfed infants, we were providing those safe BMS kits to the caregivers together with education and to help minimizing the risk of infection. We realized that mothers are literally traveling with nothing. People have lost everything before getting to the boat at the Turkish border. They just leave everything. They don't even have paper sometimes. They don't even have money. And we've seen people traveling with only blankets. They were with the UNHCR blankets, and that was just the main and essential item for them because they didn't know where they would sleep the next night. So the safe BMS kit was in a backpack, and that was just totally unsuitable. They couldn't carry it. That wasn't part of the items that they would choose to keep with them. Another challenge is the behavior change in terms of cup feeding. It takes a lot of time. And so when people have 5 minutes, they can take the cup. You don't know if they will use it. Violation of the code, we talked about it, a lot of donation of breast milk substitutes, and not only by non-formal actors, volunteers, but formal actors as well, who were involved in the crisis. The high number of actors, we've talked about it, language barriers. Yes, again, I'm emphasizing it. That was really difficult to be able to have interpreters. Through in some centers, our counselors became almost Arabic and Farsi speakers, but yeah. And lack of spaces and facilities. We were in situations in some camps that were overcrowded. People were sleeping in the open, so it was difficult for us to even have a small tent or a small housing unit to host our activities. I realized that we have listed only the challenges, but there were a lot of successes also that we can discuss. So the next step, as you said, the crisis is still ongoing. So what's next is our programming continues in most of the countries. So we work in Serbia, Croatia, Macedonia, and Greece. But we have this big focus in Greece, obviously, with more than 55,000 people at the moment stranded there, 30 plus sites open in the mainlands and in the islands with very different settings. Some of them are closed detention centers with a very challenging access. Some of them are open detention centers. We have still informal camps with many actors involved, formal camps as well. So people are moving as well from a transit situation. Most of them are not traveling anymore, but are staying in those camps. So our challenges and our the nutrition challenges change as well, meaning that our ICF is still the priority, but we also know that we need to work closer with food providers because they are the one in detention centers, for example. Authorities, militaries, armies are responsible of the food distribution, so we need to ensure that the needs of infant and young children are respected, that powdered milk is not going to be distributed, for example, but also for children under 5, that the risk of acute malnutrition that you were talking about could be increased. We need to monitor the situation. For pregnant and lactating women, they are part of the vulnerable population as well. We need to document as well. It's been several months and we have listed a lot of challenges. The interim guidance is still under interim, so we need to learn the lessons not learned, or we need to gather these lessons to know what's the way forward and how we can revise those practices if there is a need. We need to ensure that everything would be documented to be able to continue the capacity development, meaning that the crisis is still ongoing. We are not facing the same situation than 6 months ago, but in Greece, for example, the idea is now to see how we can better position ourselves to better support the Ministry of Health or the different authorities at local and at national level in order to push the ICF issues forward in the agenda. So, yes, that's the next step. The last slide is our contact, Megan and I. I think we are on time. I don't know if we have some time for questions and answers, but I think that we will be happy to answer if any. No. Thank you. Thanks a lot for your attention.